Thank you, Basim. So, good morning. Thank you very much for coming early this morning after a great night last night, I hope. I had to leave, but I hope you had fun. So, I'm very excited to give this talk today because I'm actually celebrating 10 years in Oxford this week. 10 years working with Chris Redman, 10 years working on intrapartum fetal monitoring. So, 10 years is a big number, and it makes you reflect. So, you can tell me after the talk whether we've achieved enough for these 10 years. But I must admit that in these 10 years, I didn't always work in the classical sense on intrapartum fetal monitoring. So about 2 years of it went into having my babies, which I was told it was part of the job. So this is, I finally, with my baby, which I had this year, and that's him, I managed to get an intrapartum CTG trace. This is the end of second stage, and he arrived towards the end of this trace. In the UK, it's not very easy to get fetal monitoring during labor. And if you're actually low-risk pregnancy, you need to beg them. It took me about 12 hours to convince them to monitor me with this one. And with my big boy, who has to be part of this talk, otherwise he would be too jealous, they didn't give me monitoring, even though I really wanted it. So we don't monitor everybody, and that's a huge issue, I would say. I don't know if it's a problem, but why we don't monitor low-risk pregnancies? Because the false positive rate is so high that someone somewhere in a mental way has calculated the ratio between false positives and true positives that it's worth saving or monitoring. So that's probably the first point I wanted to make. Another 2 years of this 10 years, I've also didn't work in the classical sense because I spent them trying to secure funding. And I'm glad to say that I've secured now 3 years of funding after spending 2 years, applying for it. And the reason for it is very much the same reason why I get our papers rejected a lot. And the rejections are always from anonymous reviewers, apart from once when someone put their name. Jenny Westgate put her name at the bottom after trashing us completely. But what I want to say is that the problems are never with the research we've actually done. The problems are always with the concept. So the problems are always with the outcome that we touched on yesterday. The problems are always with the concept. So I've put this robot here, it's a NASA robot originally. Are we trying to deliver babies with robots? Are we doing artificial intelligence for fetal monitoring? Or are we assisting clinicians to do their job? And are we assisting them by visual aid? So the concept of data-driven CTG is different, and I'll try to explain it now. So for example, we saw Ines yesterday morning talking about the CIS-Porto system, which takes the knowledge of clinicians. They've spent years looking at CTGs, they've designed the FIGO guidelines now, they give you guidelines of what you want to read in the CTG, and CIS-Porto is giving you the visual aid to do that. So if you don't want to ask the questions, how often is CIS-Porto right or wrong, then you don't need to worry about data, and you don't need to worry about the outcome of labor. That's what Infant did as well, and we are going to hear later today from the Peter Brocklehurst, who was the Infant clinical trial. So when you have a software where it's just mimicking what the doctors do, then that's one thing, that's a visual aid. When you have data-driven CTG, what you're trying to do is you're learning information from the data. It could be completely new information, and that's what we touched on yesterday. You could use deep learning nowadays. You could use very sophisticated methods. You can use simple methods as well, but what you do is you read something in the CTG and you need to map it to something in the data to say the outcome is good or bad. You need to be able to punish or reward your robot. Otherwise, you can't do it. So all of the discussions about pH or not pH, they are so important because we can't, what Peter was trying to say yesterday, is we can't do anything as signal processing if we don't know what the aim is. So I can't underline this enough. It's a huge problem in obstetrics. When you have doctors who are assessing your CTGs, no one's auditing these doctors afterwards. How do we know they did a great job or no? So for example, Austin Ogumodu here, it's a great obstetrician as far as I can tell, because I have great respect for him, but do we have a measure for how well he did last year? Did he do better than the year before? Did he do better than the 5 years before? Are you getting better, or are you getting actually worse at the way you pick up babies who need help during labor? Or do you miss more than you missed before? And this kind of question, we are not able to audit neither the clinicians, neither reward or punish after softwares, because we are muddled in all these problems about what is good outcome, what is bad outcome. And Barry yesterday was suggesting an interesting new perspective to look at the number of crash sections, so the number of crash sections or operative deliveries which were presumably provoked by the CTG or for presumed fetal compromise. And that sounded like a good idea until you think about, yes, you want to do that without increasing the number of adverse outcome. And then you still got to the problem, what is adverse outcome? And that adverse outcome, whatever that is, it's so remote from the beginning of the CTG trace that you sometimes, it's even more complicated. So we're looking at a very complicated problem. And so I just want to start with this slide and say, yes, the CTG data-driven interpretation is actually not that different than trying to teach our clinicians to do a better job using the data, using their actual performance. You need to have a clear outcome. And there are problems. Obviously, we've got treatment paradox. I want to just start with the problems and then move on to what the treatment paradox is a big one. And Barry as well yesterday said something very, very relevant in between all the other things he said as well that were relevant. And it was that if you're getting it right, you will start seeing this relationship disappear. You will start seeing abnormal CTG patterns relating to adverse outcome because you will be able to prevent the adverse outcomes. So if you are doing a successful intervention of some sort, you're losing your association. And that's seen in many other fields. And I think Chris can explain a bit later more about how we have, for example, similar with blood pressure and preeclampsia and the outcomes of that, and other fields where you have some kind of marker, and because you've got a treatment paradox and you intervene in some way, you actually don't have the adverse outcome that you set up. And with the CTG controversy, if we stop doing CTG monitoring now altogether, and Barry touched on that, some people would like to do that, what's the point of it? The false positive rate is massive. We don't really know if we're doing it better. Are we going to start having more stillbirths in labor? Because that's what it was designed originally for, and we very rarely have. We don't have, in Oxford, we haven't had a baby die on the trace. We don't. We've got 1 or 2 traces where the baby died kind of on the trace, but the trace started just now. Just literally, you've got like 20 minutes of trace, and then the baby dies. We don't have a trace where it's going on and on and on and on, and then the baby dies. We don't. It didn't happen for all these years. So I hope that didn't make it more complicated now, but there are a lot of complicated issues, and that's taken a lot of time. And as a signal processing expert originally, that's been pretty much a waste of my time, because in that time I could have been developing better techniques. But we've had to take a massive step back and ask all these questions of what is the outcome? Does it make sense at all trying to learn from the data? Why are we doing what we are doing? If it's not a well-defined problem, if it's such a complex CTG, then let's go and apply our skills for something else and abandon all these millions of women that deliver this way. There is a high signal loss, and I'll touch on that. And going back to this trace, do you see the signal loss? This is a very motivated mother who wanted CTG monitoring, who begged for CTG monitoring. The midwife was, 95% of her attention was on this signal loss, and I'm not even fat. Uli, Philips, what are you doing? This is a Philips monitor. This is not 21st century. I'm really frustrated. It's one thing to hear about it. It's another thing to be in pain in second stage labor and to try to deal with that. I was about here, leave the stupid monitor off. Literally, enough of that monitor, and I know the baby is fine, and I know the baby is coming out. But it's a huge problem. This is not user-friendly. How many years are we going to stay with this? So the signals are bad, the qualities are bad, women don't like it, and oh my God. Most importantly, here at the bottom, I just can't get this in people's heads right. It's only risk assessment. So you've got a proxy of a proxy of a proxy. We have that in clinical practice all the time. It's evidence-based medicine. You give an estimate and you communicate with patients and you give them a risk assessment of what to expect. You don't give them a diagnosis. They are diagnostic tests in many cases, not in this case. It's CTG, it's a heart rate, it's very limited. It can tell you maybe something, and I'll show you what I think it can tell you, but it's limited. Stop trying to make it a diagnostic tool. Stop trying to want to make it work perfect. No, it's not going to work perfect. Do we have anything better right now? No, but we should work towards getting something better, maybe completely new modality. So that's very important to begin with. So now, going to the data, if we agree that the data-driven concept is valid, so we have that data, using expert knowledge, using just data, using deep learning, using machines, using computer power, 21st century techniques, we want to learn from that data. And we need some kind of outcome to say when our algorithms are doing good or bad. So it's a small robot, and you need to be able to smack it on the head and say, no, 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 that's a bad idea, and reward it and give it a carrot and say, that's a great idea. It's as simple as that. So we then need the data. And in Oxford, I've been privileged to work with a lot of data. Chris Redman set that up in 1993. So everybody who is monitoring our hospital of the Hill is in our database. About 60% of women are monitored roughly in the UK, and we are not an exception at Oxford. So unfortunately, we don't have everybody. And that is a bit of a limitation, obviously. There is a lot of detail about the labors, a lot of detail about the outcomes, so we can do a lot of things with that data. We exclude some fairly obvious thing, and the core database is almost 60,000 intrapartum CTGs with all the details. So it's really, really powerful database. Up to year 2000, we were, the electronic database would store the information about the mode of delivery, so you would know whether it's cesarean section or whether it was operative delivery, but you wouldn't know what was the primary reason for that intervention. So you wouldn't know whether it was presumed fetal compromise, or whether it was prolonged labor or maternal reason and so on. So if we need to know, and I'll talk about why it's that important, when we need to know what the doctors did and why, we work with this data set, so we start losing data. And then the cord gases, the big problem with the cord gases, we don't sample uniformly here. And it's actually ongoing and changing practice, right? We're looking here at very large span of time. And things are changing as well. At the moment, we are moving towards delayed cord clamping and so on. So this is not a uniform practice across the years, and it's not a uniform practice across clinicians, because it's at the discretion of the doctor, so they might do it, they might not do it. But when we want to know the cord gases, then you've got quite a lot of bias already in that database. That's we end up with a little short of 23,000. So the problem of outcome, what is the goal of intrapartum CTG? So after a lot of up and down, backward, forward, numerous rejections of all, we've kind of come up with this. And I hope that's good enough for majority of people. So here's the severe compromise group. So it's a composite outcome. It's quite similar to what Infant did in their clinical trial. And we'll talk about that hopefully later with Peter. It's a tricky bit, but there is always someone who will now discuss why this and not another. And there is always someone who has opinion. There is no perfect well-defined. It's good if we start doing it the same way across the groups and across the continents. That would be useful if we start using the same metrics. But even if we don't, that's a pretty obvious, if the baby either required intubation or not. So the resuscitation is cardiac massage or intubation. The baby either died or lived. That's a little bit objective, right? And we keep here the pH group. So these are babies with acidemia below 705, and I'll mention, I'm happy to talk later actually, why not base deficit. We've done a lot of research with it. We just don't find use for base deficit in our database. There is no need for it. But I'm happy to discuss. We've got the base deficits here as well. We just don't use them because we don't need them. So around 30% in severe compromise, we've got also acidemia, and metabolic acidemia is usually. And here is this kind of intermediate group or moderate group, which is acidotic but not but doesn't have any of these severe problems. So then you've got this intermediate group, and that's quite important one because of the treatment paradox and because of the censorship of the data. Because when we talk about how many of these deliveries were delivered by doctors because of presumed fetal compromise or another reason, and then they end up in that group, you can kind of say that was probably a true positive. You don't want to punish your doctor for that maybe, or do you? I don't know, I'll ask Austin again later. So if a doctor delivered with a crush section a baby and the baby has a pH around here, if the baby is well and kicking, it's very questionable. So we have that. And as we discussed yesterday, pH is just one thing, and I'll talk about it in a bit more. Very important to have a normal group so that you know these babies were far, and if they don't have anything clinically going on, you know they were far from the acidotic important threshold. So you don't want to be intervening here. If your software is reading this kind of trace that ended up like this and is going red alert, well, you want to punish that software. This is not a very good robot. No, you want to say no. At least that's what we believe. So that might look, this is a simplified version of the original pathways to brain injury. So in this whole quest to define what's the purpose of CTG monitoring. I've worked on this with Ugu, Madhu, Redman, and Schifrin. I mean, I've consulted with them. I'm very happy to keep on here. I've sent it to Laura Bennett at Auckland. She was very busy. I'm very happy to hear from anybody who wants to contribute. Let's get that to kind of beautiful, more agreeable. Can we get that to somewhere where people can agree on? How do you end up with a hypoxic ischemic injury during labor? What are the pathways to get there? And where is the CTG's role? Are these cases where the CTG can? What are the CTG patterns in these pathways that could probably give you a red alert? So this is our severe compromise. I put it here on purpose because it's not a perfectly defined measure, and we do have HIE as a diagnosis since 2012, and we can use it, but that's not perfect at all as well. So we know that a big part of these severe compromises would come from hypoxic ischemic injury, and if they've got an MRI the way they would do now, you would actually see a hypoxic ischemic injury, so majority of them. But how did you end up with this one? So these are three pathways. This is the standard thing that most people, when we talk about intrapartum hypoxia and intrapartum injury, think about. I think Barry did a great job yesterday discussing these things, so I probably skipped through, but you know, this is blood pressure, cerebral blood pressure, this is intracranial pressure, mechanical head compression during fetal expulsion. Very controversial. This is very much because it makes sense to me what Barry is saying, but there is no, this is Barry Schifrin a lot. And a lot of clinicians don't like that branch. I get a lot of, why do you trust that person? He's not in this morning, that's why I say that. Makes sense, but I hope Chris Lear is going to talk about it later today as well from the physiology point of view. He will talk a lot about that. So I'll skip through it. No one mentioned so far in this workshop the antepartum brain injury. During the challenge, we will look at one or two patterns where we believe that's what happened. And this is a baby that probably can't go through that pathway. So it already has the injury, it doesn't have the mechanisms, but it's very individualized, so some babies could, some babies couldn't. But that's another way. And I don't even talk about infection and systematic inflammation. That also sensitize the babies very likely to, and I think the Auckland group is doing research with that. So then we would have a small hypoxic injury or small hypoxic pressure during labor, but this already sensitized baby would suffer. Anyway, so in a way, yeah, happy to come back to this one later. I want to introduce the Everest plot. If you haven't read it in our papers, we find that very important, very useful. It's just a graph. Because when you have a very rare outcome, the rock curves are just not very useful. Your sensitivity is squashed in the middle, and what we want to know, it's just another way of displaying association between a continuous predictor and an outcome of interest. So if this was decreasing pH value, all of the data, so you need to have a cohort for this. You can't just have two extreme ends of data. We only work with cohorts because of the false positive rate and wanting to monitor the false positive rate. And so 5% of data on this graph, you could zoom in and out. You could have 1%, you could have 20%, it doesn't matter. So you've got equal number of cases, more or less, percentage of data in each of these blobs. And then they are grouped according to changing value of the continuous predictor. So then you want to see in each of these group of babies, what is your rate of compromise, right? And in a perfect predictor, you would have something like this. Up until a certain threshold, nobody will have compromise. You don't have any false positives. And then after a certain threshold, everybody's got the compromise. So you've got 100% positive predictive value. So that would be in a perfect scenario. And the reason why, the main thing is it's not something that, the main thing is that you group them, you normalize the data, you group them in equal sizes, because otherwise your compromises are so rare. So using this graph, for example, the role of pH, and that's published, and there's a lot more detail to these graphs in the publication. So that took massive part of my signal processing time. So this is pH getting worse and worse, and you take a hardcore, rare, bad outcome, neonatal death, and you see no actual increase of the risk. So you can go through the pH thresholds with no increase for the risk of death. And that increase is only in the very end here, below 705. And if you stretch it more, so if you do 1% of data in groups, then you would see again only, so the lower your pH, that's where you get bigger and bigger peak. But if you have something milder like resuscitation, which is either intubation or cardiac massage or both, the risk increases at a milder threshold. That's quite mild threshold. And you've got a threefold increase here, about 7.15. And then it shoots. It's not more than 9%. It's not 100%, nowhere near. pH is a risk factor. And Barry said it yesterday as well. It's a risk factor for compromise. It's not a diagnosis. It can't be. It's very individualized to the baby. We don't fully understand it. It's volatile. It changes. What it does, it stratifies the severity of outcome. So if you know you're here, you know you were not at an increased risk of fetal death, but you were at an increased risk of milder things. And if you have a look at the paper, you'll see, for example, facial mask, which is just helping the baby breathe a little at the beginning. The risk increases somewhere here. And doctors haven't looked at the pH values when they put the mask on. There is something there in these babies that they noticed, and it is related to pH. So that's the point I wanted to make. There is some use for it, but obviously we can't over-rely on it. But in principle, if you were to prevent all of the acidemia, you had some magic too, and prevent all of the acidemia, you would be doing something. You would be going back to this one. You would be doing something here on this pathway. You are not going to prevent these ones, you're not going to prevent these ones, you're not going to prevent these ones, but you will do something. So I wouldn't throw it away personally. Okay, now the other thing on, how do we know? So we've got a system, we've got, sorry to say again, Porto, but we saw it yesterday, it's a ready system, it's been under development for a very long time, a lot of work, and I admire the work that's gone into it because there's been a lot of testing. Like people have took their time with it and made sure it works very well, unlike the infant, and that's my opinion. And there's so much going on with the CTG that there's a lot of work on it. And you take a ready system and then you say, okay, I want it to be data-driven. I want to see how it performs on data. Or you take a doctor and you see how they are doing. So these are the doctors in our hospital since 1993. So now that we've defined these 4 groups, independent of them, then we can see how did they perform. So you can see here the group of severe babies. Doctors in our hospital intervened for presumed fetal compromise in about 37% of those. They intervened for other reasons in a good proportion of them still. Some of them were spontaneous deliveries. And these are monitored babies. These are not babies these are not mothers that just arrived and delivered. These are babies that were in the hospital and were monitored, right? Because the ones that just came in and delivered, they wouldn't be in this database. So they were monitored, there was clinical attention, but about 63% of these are severely compromised babies that were not looking good at all when they arrived. 63% of them were kind of like, oh, a surprise to the doctors. Like, they were a bit like, oh, I didn't quite see that coming. That's a lot. And you need to see that when you are designing a software, you need to be gentle to your software. If doctors are doing this, and this is, your software is not going to be doing 100%, or at least not straight away. And then you've got the moderate group, so this is low pH without any kind of severe other compromise, which a lot of doctors are happy with, and they say, okay, it's low pH, baby's kicking in pink, I don't mind. This is the mild one, this is the normal. What you see is a very clear titration. I think that's very important, because this means so doctors are doing something right? And I'm going to show you maybe later another graph, where you can see the more severe the compromise, the more intervention there was in that group. Even though there was intervention, they were not able to prevent all of them, but they prevented probably some. But you see a good titration in a good software, a good robot would be doing that as well. Good artificial intelligence should be able to titrate. So about the signal processing side of things a little bit, we've been working with a lot of features. So we talked about features yesterday. You've got a CTG, you need to take a window out of it, how long. It's a question, 5, 10, 15, 20, 30 minutes, and then you can characterize it, and that's what doctors do as well. And you've got here a lot of the clinical features like baseline, long to short-term variability, contractions, decelerations, and these are all, up until here, you've got visual related, so doctor related features, so they're clinical features. And kind of here, we've got a small sample of data-driven features. So these are features that someone ran a software through the CTGs and found out the characteristics, statistical ones that are linked to outcome without necessarily linking to the clinicians. So I'm going to talk about PRSA, decelerative capacity in particular, in labor, because that's our best feature, and I'll show you why. Yeah, but we do have all of this, and what I wanted to mention, it's a lot of time has gone into validating baseline. You can't just do an algorithm for baseline, have two doctors have a look at it and say, oh, that looks right. It doesn't work like this. You need to have a statistical sample of your data. You need to look for these cases where baseline wouldn't work, and then have clinical opinions. It's a lot of work. A lot of these things are published as well. Number of contractions and so on. I'll touch on that later. PRSA, we were talking about it yesterday, so Maria was very helpfully explaining how it's calculated. Here is a simplified graph. So PRSA, decelerative capacity, depends on two parameters. They're just smoothing parameters. It tells you how much to smooth, so think about it as smoothing in the data. But if these parameters were 1, so you actually were not smoothing, they were just 1, they were the smallest value, that's what DC would be doing, decelerative capacity, DC. You know, if you were computing variability and we were including decelerations and all the whole signal, and that's what we do in Oxford, we include the whole signal, that's what you would be looking at, these oscillations from one heart rate measurement to the next, to the next, to the next. But in DC, we take only the downward ones. It's a very, very simple technique. And then we take the average in that window. So it's a smoothing on top of smoothing on top of smoothing. And because our parameters are not exactly 1, there is a bit of smoothing here and a bit of smoothing here. But for visual purposes, for clinicians, I think this is the best way to think about it. You're just looking at the downward trend. And that's why I say that this is an interesting measure of the time you spend at baseline, because the longer your segments at baseline are, the smaller your blobs would be, the smaller your DC will be. The more decelerations you have, the deeper they are, the longer they last, you're getting higher DC. And that's why it's so well related to acidemia and to some other outcomes, and I'll show you why. It's just an overview. And I've got an example here that I like to show, just to show that DC is not some kind of, it's very, very easy to understand visually, and I've been working with it about 5, 6 years, 7 years now, and you learn to see it in the CTG. So I'm hopeful. I think doctors would be able to work with it in many ways. If you didn't want to do AE, if you wanted to do visual aid, you can just display the DC for the trace and help doctors read it. So this is an obvious trace. You see a baby here, a bit low variability, but fairly normal, tachycardic, quite tachycardic, but in a sense of decels, it doesn't. So it gets progressive decels, and then it loses its baseline, and this is delivered here. This is our algorithms. So the trace starts at 8, so that's about here. So see, it's already tachycardic. It was quite normal before. I don't show the whole graph, but it was actually quite normal. It took hours to develop. So yeah, and then your baseline keeps on detecting, and then it loses at the end. And this is your DC. And it's quite normal around 3. It kind of gets abnormally low around here. So that's this very low variability here. And then it picks up, and then it crosses around 10 o'clock. When you go here to this crazy bit, that's when it shoots up above 5, 6, and these are the clinically relevant thresholds, and I'll show them. But it's something you can see in the trace. But it's a great tool, because then with eyes you can't explore 60,000, but with DC you can. This is now 23,000, so this is the smaller data set. And this is now I've got a continuous measure of the CTG. It's extremely simple. I run through the CTG with a window, and I look for the maximum PRSA that CTG reached at any point. It could be very early, it could be late. Simplified. And this is what I get. So the DC is a predictor of acidemia. You go here. There is no increase of risk until you reach a threshold of about 5.8. Then the risk increases a little bit, so with 50%, from 2 to 3%, so 50% increase of the risk. And then as you get even higher thresholds, then you go. So that's the general population here. That's the majority of cases. And you go about, risk about 7%. So it's not 100%, nowhere near, right? But it's doing something, and you can see where your threshold is. If you look at this thick meconium group, and I'll talk about that, no wonder our team was called meconium yesterday in the treasure hunt. I think about meconium all the time. Here, this population of babies, the risk increases in a lot milder threshold. So if there is no thick meconium or other risk factors that we can talk about, that's no threshold that you want to be thinking about intervening. But if you're coming here, and then obviously the risk is more than double. And I'll talk about that in a bit. So in a simplified way, and that's going to be the system you'll see later perform. So that's the very early Oxys 1.0, very early prototype, what I call backbone. And so here you've got a trace. Every 5 minutes, the DC is recalculated. So you've got a moving window. It overlaps, and every 5 minutes, it recalculates. It's going up and down. Here you can see very good cyclicity. So good long traces of healthy babies would actually have that. So you can spot that. Often I don't need to look at the CTG anymore. I actually can get a lot of information by just looking at this personally. I can tell you a lot about the trace. And then this one was going up, up, up. Then it passed the threshold, 5.8. Then it's a high risk. And what we've done now for the challenge and for our papers is that only one passing of the threshold is enough. So even if it recovered afterwards, you've already highlighted this trace as a high risk. And we've done quite a lot of work on that, why. And I'm happy to discuss that later. Obviously, if it stays high up, that's an even higher risk than if it recovered. But even if it recovered, you've already have a high risk CTG, as far as we can see in our data. So that was our benchmark. Coming back to this slide, this is what clinicians do. So now we can use this fancy thing and do the same. So this is how we perform compared to clinicians. A bit better here, a bit better here. So, well, this we don't know. We said we are not, this we don't, this is a no man's land because it's this intermediate group. We don't want to punish or reward. We don't want, we don't know what to do with it. We're happy. Then it's doing quite well here, not so great here with severe compromise. And remember, this is about 70% of babies here don't have acidemia. 30% do. But it's doing something for such a very simple technique. We've been happy with that. Then you go here and look at these clinical risk factors. And going to the point that Dr. Quirk made yesterday about if you have, he was talking about two normal CTGs. Can you see something here that will tell you which one will go into a compromised direction and which one would remain normal, or which one the baby would stay normal? I've never actually thought about it until yesterday and until Dr. Quirk said this, in a sense, is there something in the CTG invisible to the naked eye, but something you can measure with machines that would tell you which baby would go up or down in the normal while it's still normal? It sounds unlikely to me personally, but I'll be very happy to see devices like Monica or something else where you get a very, very good beat to beat. Or Rick will talk tomorrow about Eindhoven's research on that as well. What we tend to think in Oxford, and in my head what I tend to think as well, is that the risk factors, the way you saw that babies are sensitized to something, that's what you want to look at. Because you might have two babies with similar CTG patterns, but if there is a risk factor, this baby doesn't have a reserve to sustain the same degree of kicking, as Barry was saying yesterday. So we tend to think, and that's what you can see with data like this. For example, the background risk, looking at 60,000, so the big data set, because when I don't need to, I don't go to the smaller data sets. This is the background risk, even after all the intervention. If you've got a decelerative capacity above that threshold, you double the risk. It's not very high, but it is 2 times higher. But if you know, that's just an example of the clinical factors. If you've got a baby, first baby of an older mother, you also double that risk already, just by that. And then on top of that, if there is thick meconium, you get even higher risk. And then if there is, on top of that, the CTG, is showing you that that baby is not coping so well, you have even higher risk. So that's individualized risk. So that's where we are moving, that's where we've moved to, and that's where we plan to keep the direction. And Barry will talk tomorrow about his fetal reserve index, where he includes a lot of clinical factors, and they studied. So we generally believe that the clinical factors can play a major role. And again, linking to the other things in this workshop, so during the CTG challenge today in the afternoon, you will see clinicians will be moaning that evaluating the CTG in vacuum, as Dr. Quirk put it, not knowing what's going on around it, it's really difficult, right? But actually, that is what we are asking our algorithms to do. That is what you're asking Sysporto to do. Look at this CTG, you don't know anything, and evaluate it. You could do something, but you're not going to be as good as when you have more information, where you are in labor. And what Barry was talking yesterday about, how you need to process the first stage differently than the second stage. It's very much true, and we haven't done that yet, but it's very easy to do. You want to, if it's second stage, you want to tell your algorithm, and the computer science is there. So in terms of algorithms, computer power, what Peter yesterday was saying was great. We can do anything. We can do anything. The power is there. Someone needs to tell us what to do. That's possible. That's not a problem to be done if you have enough data. So that's where we are. And then we use that information, just thick meconium and preeclampsia, just babies that already potentially don't have a very good reserve. And I'm happy to talk about thick meconium and another. Why thick meconium is that? So we improved a bit. So that's 1.3. Then, and that's the data-driven concept that I've been trying to convince these anonymous reviewers that's valid. That's what you do. You look at the data and you get better. Then we do something else. So we saw here, we weren't very happy. We were like, okay, what is going on with these severe compromises? Then we looked at the traces, and it was very easy, for example, to do that. We defined a non-reactive, and it makes sense clinically, and it links to the antipartum system, and we've got those Redman here, we use it a lot, and you want to have some kind of a link between when you monitor with those Redman and when you monitor with intrapartum. So anyway, so we use this alliterative capacity. You can do that with other, you can do it with STV, with other computerized measures, it's not a problem. But we anyways calculate DC already, so actually very low DCs relate very well to flat traces, no accelerations. And it's a pragmatic study because you take the CTG as it was. You don't have some artificial admission traces where were done only for the study. Whatever they monitored, that's what we take. And it's pretty powerful. So these are just some examples, I don't have time. These are some flat traces. This is those Redman STV, I just show it for clinical purpose. DC would detect that perfectly. Skipping. So here the background risk is a bit different because it's a different data set. But the background risk for severe compromise on a large, this is over 50,000 cases, it's 124. If you have non-reactive first hour, it doesn't matter when it started. I mean, it matters, the earlier the better, but we just use the pragmatic data that we have. Sorry. And then if you have thick meconium, you're already in a massive risk. So you don't want to be monitoring this lady for another 10 hours, as far as I understand it. So we use that information, right, this non-reactive first hour. So what Barry was saying very well yesterday, you need to start with a normal trace. If you start with abnormal trace, but how do you define abnormal admission trace? That's a bit different. That's an abnormal admission trace, very abnormal admission trace. When I was showing this to doctors in my hospital, I had someone that I really respect, she's brilliant, and someone else, they both tell me, Antonio, we see this all the time. In admission, we send them go have coffee, move around. Seriously, that's what two people told me, and I was like, no, we are talking about we can't understand each other. We're not talking. This is This is in 0.4% of 50-something thousand traces. No, you don't see that every day, but it's just something that you need to look at these traces long enough, I guess, to be understanding. Going back. Anyway, so we use that information, and then we get to 1.5. See, that looks even better. So that's what we managed to publish, right? So that's been out now, and you can see more details. You get a good titration, you get more severe compromises because these are babies that didn't have a poor pH necessarily. These are babies that started this way. And so on. But what I wanted to convince you here now is this data-driven concept. Do you want to test this in a clinical trial? No, no, thank you. And I think Jean-François Pierry yesterday was saying, you know, get your algorithms right before you are doing big clinical trials, absolutely. And you know, anyways. So we want to do that a lot better. So this is very simple, remember, this is extremely simple, this is PRSA. It's very quick to compute. We don't even use baseline at the moment. Going back to the big data set, in the severe compromise sensitivity, then you've got a bit lower sensitivities because it's a lower risk data set. Yes, okay. Few other things mentioning, in Oxford we've got, you know, obviously a lot of signal processing. So this was more for the signal processing people. We only use windows with 50% quality of the signal. So we kind of chunk this kind of part. So this is just a pie chart of the distribution of windows with signal quality in the database. So we kind of chunk the ones, and there is a reason for it. And there's been quite a lot of research here from my student. It's unpublished, unfortunately, for now. Why 0.5 or 50% signal quality in a window, but you can choose that using the data. Final remark I wanted to do to the signal processing people of something that I would be quite interested to hear. We published this paper not long ago, talking about the future, talking about transabdominal monitoring. So we are using all this data, but that's data from the past, and we want it to be in the future. I do believe in transabdominal technologies in the future, obviously in the beat-to-beat variation and everything, but given that we are putting all that work in the smoothed signal, would that be transferable? So would oxys be transferable to the future devices that would be using transabdominal? And I think that's an important problem, so that I want to make that point for everybody to think about. And I'm happy to hear later on, that's quite controversial of how we did it, the mapping between, yeah, I don't have time, but I'm happy to look at that later if you want to. But I just want to stress, please have a look at this paper, have a look at this conversion. I'm happy to show it later, and I'm happy to hear back how the red blob here is our DC. So it shows very good correlation with itself, so about 0.8% when simultaneously a Monica device was used and a standard Doppler. So you get the two CTG signals, so you get all the smoothing, you lose all the beat-to-beat variation. No, you actually don't lose, sorry. You use the beat-to-beat R2R intervals for Montessori, and then you map it to your CPD, and then you calculate your DC and they map. Sorry, that's it. Thank you.
So since we have started 10 minutes late, we have time for 1-2 questions.
But it's 30 plus 15, you know.
Yeah. Water too. Okay. So,
Martin.
Thank you very much. It was an excellent talk. And I love that you put in that slide with inputs from the various colleagues on the physiology and sort of making that attempt to think about what are we actually measuring. So I think that's key. Would you be so kind to go back to that one? I think that in many ways that's you know, the crown slide where all the things go back to in many ways. And I just wanted to make a suggestion that essentially I think it's a perfect diagram in many ways, and we can simply think about adding or replacing intrapartum hypoxia with a general decrease in energy supply, and that can be simply due to a number of things, such as hypoxia, but also infection leads essentially to similar effects. And so you can, what I'm saying is you can easily incorporate additional pathophysiological effects without basically changing much of the downstream. In fact, I also want you to sensitize everyone to the fact that there is an ongoing discussion to what extent the lactate obtained from the cord blood is a powerful indicator not only of acidemia as we think about it, but also of the infection. In fact, in adults, lactate is used as one of the infection indicators. So I find it difficult in the delivery room to get them to measure lactate. We basically have to specifically ask for it and make the magic stick out on the form, but I think it would be worth it and a powerful addition to endpoints. I'd love to welcome people who actually do obstetrics every day to weigh in, but there is this discussion that lactate would significantly add to the more salient outcomes on the side of the sequelae and things like that. So just think worth kind of keeping that in mind. Metabolic acidemia is perhaps more interesting to me even than the general pH. So two things. So I think that this is a fantastic basis. Do you have are you aiming to put this into article of sorts, review, whatever?
So far it's hanging. I think it's very important discussion to go on in Nigeria. We publish it, yes.
I think it would be good.
I'm happy to get you on board. Jumping? That's why
I'm not attempting to but I just think it's great. We don't do enough of that.
Thank you. No, I've been sending it around and asking for input, and ideally we would want to get some consensus on it. I can publish it.
Okay. So another question.
Yeah, just a comment about that diagram that's also up there, and relating back to Dr. Schiffer's talk yesterday. There needs to be, before that's going to be published, there needs to be a whole lot more written, data written, and peer-reviewed on the effect of mechanical head compression on anything that goes on in the fetus, because what he really described yesterday is an extreme version of maladaptive distribution of blood flow. When he talked about clamping, some animals carotid artery. So I think that that's all I'm going to say about that.
I hope that Chris is still right. We'll also shed some light on this. Please say yes. No? Okay, he'll shed more controversy.
Okay, so another question. Yeah.
Thank you, Antonia, for the presentation. My question is related to maybe the previous where you introduces the threshold about the choice about the pH values to classify as a severe or mild. This was blue and white. It is the table. It doesn't matter. Okay. And always, and we discussed even facing the challenge. We discussed about the CRISP values of the threshold that are used to classify these different behavior, these different outcomes. The question is it possible to think to the threshold that even defined in a crisp way by clinician could become, I could say, fuzzy in terms of...
705 you're talking about. Are you talking about the pH threshold?
Yeah, yeah.
The problem about the pH threshold.
Right.
It's as old as the world. Yes, my answer to that is that it doesn't matter what the threshold you're using it. And I had somewhere a graph of them, which is going to kill me, so I'll show you later. Where the more severe your acidemia, the more predictive your definitions are and your models. So the higher your sensitivity is. You see what I mean? So if you use 7.1, you will see something. If you use 7.15, you will see something because pH is grading the severity. And clinical intervention is quite well linked to it. So I'll show you later. Okay, so.
Great. So, thank you.
So I don't worry so much about thresholds. It's waste of time.
Okay.
What works for 705, we work for 7, we work for 695, and we work for 7.1. Just the rates will be a bit different. So your risk will be different, the number will be different. But you want to see titration, that's why I'm showing it. If you have good titration,